So let me start by my presentation on B-HEX Pupil Expander, the tips and tricks. I have a financial interest in the B-HEX, and I do acknowledge the contribution of Dr. Deepak and Dr. Michael Henry. Now, we had a survey in 2020, last lockdown, and we found out that the B-HEX, of course, this was among the persons who responded. It's not important to see the numbers, but yes, B-HEX was being used in a significant number of patients. Now, what we wanted to find out was a good number of patients were happy, but there were a significant number who were unhappy. So we needed to find out why were these patients unhappy. So what instruments did the unhappy users use? The happy users used the 23 gauge forceps, whereas the unhappy users used the Sinskey hook. Now, what did the happy users do otherwise? They stretched the rigid pupil, whereas the unhappy users didn't stretch the pupil, couldn't assess rigidity of the pupil, and there was could not even some of them didn't respond. So I would like to emphasize those points in my presentation. So that's the B-HEX, which is a hexagon with notches and flanges, thick strong flanges, thin flexible notches, and tabs for holding with the 23 gauge forceps. That's the 23 gauge forceps. It's ergonomically designed so that the squeeze handle is in a plane perpendicular to the jaws, which open. So that makes it, and go for the original one if you can. So where do we inject viscoelastic and how much? So if we inject viscoelastic and anterior to the iris, what we're doing is basically pushing the iris against the lens, and which is counterproductive to our cause because it's going to leave no space for our devices, whether we're using iris hooks or otherwise. So the best would be to use the viscoelastic under the pupil margin so that we can lift it off and create space for the device. And a little bit of anterior bowing of the iris helps us. Now, let's look at the steps, basic steps. Visco under the iris, step 1. This is a video by Dr. Deepak Magur. It's been a teaching video for many people. And then we place the B-HEX on the iris, and then we start tucking the flanges. So there goes the first flange under the iris, pupil margin rather, and then the second alternate flange. Remember, these are marked with the holes, and that's more to identify the alternate flanges than anything else. And the tab also is helpful for holding. You could hold at the tip of the forceps. That gives you more advantage as far as negotiating those flanges is concerned. Sorry. So in 2005, Chang and Campbell told us about the IFIS pupil. So what they said was, unlike the non-elastic myotic pupil, the IFIS pupil immediately snaps back to its original size following attempts to stretch it. So small pupils are of two types, elastic and non-elastic. The elastic one is like a rubber band, and you can use any device to stretch it. Whereas the fibrous one is like a string, and you need a strong and bulky expander to stretch it. So how you wish to tear an elastic pupil or rigid pupil would depend upon whether you want to use a Kuglen hook, which gives you controlled tears, and then use a thin device which is not strong enough, or you would like to use a bulky pupil expander like the Mulligan ring or the I-ring or the APX, which is bulky but and kind of can tear the pupil but occupies a lot of space. Before you start, it would be wise to check the elasticity. A good way is to just inject BSS through the paracentesis, and if the pupil expands momentarily, you know that it's an elastic pupil. On the other hand, if you're working on a rigid pupil, how much of a BSS or viscoelastic you inject, that pupil is not going to budge. So you need to use either two Kuglen hooks or a bulky device to kind of tear that fibrous margin before we get significant purchase on that pupil. So what matters most is the elasticity of the pupil and not the size. So let's look at if size really matters. This is a less than 4 millimeter pupil, which was stretched by Dr. Deepak Magur. And now you see it's favorable enough to use a B-HEX. And this is a pretty hard cataract. It can probably get harder than this. And it's not the hardness of the cataract which matters. All that you need to do is chop it into small fragments, and you can use a 5.5 pupil that the B-HEX produces for the hardest of cataracts, and that is good for IOL implantation, and the device comes out very easily. So how big do you want the pupil to be? Just like we saw, 5.5 is good, as long as the pupil does not get smaller, and B-HEX gives you that, so you could work easily with that. Now, as far as after Capsulorhexis intraoperative miosis is concerned, a Mulligan ring or the I-ring or other devices, they have the gaps or scrolls, pockets at the sides. On a top view, you can't really see them very well. With the B-HEX, it doesn't happen that way. So the notches are staring at you, they're open. So with the top view, you can see the notches and you're full control. So as you tuck those flanges, you are absolutely ensuring that you're not engaged the capsulorhexis margin and you are in the safe plane. There's instant confirmation as you reach your comfort zone. So in a shallow anterior chamber, now B-HEX is a 75 micron device, which is thinnest of all. It's almost 1/10 the size of other devices. And the corners of the Mulligan ring is about 0.9 millimeters. And if you remember that the mid-peripheral anterior chamber is a lot shallower than the center. So that's where the corners are going to rest. And if you're going to place it on top of the iris during insertion or removal, that could be a tight situation. So you see over here, even in a shallow anterior chamber, Ansatz phaco is done, CTR is used, IOL is implanted, no issues at all. And this is a wonderful video which has been recently published by American Academy on their website for a 1-minute video by Dr. Michael Henry. And it's a shallow anterior chamber with a glaucoma tube shunt in place, a single incision used to expand the pupil with the B-HEX. And the thin B-HEX is maneuvered around the tube easily without any collateral damage. Now, this is a shallow anterior chamber. You have the tube over there, and you see the flange is being tucked. It's maneuvered around the tube and tucked under the pupil margin. No other device would allow you the liberty of doing such maneuvers and still not touch the endothelium or cause damage to the pupil margin. So, while implanting the IOL, I would urge you to ensure that the trailing haptic goes into the bag in one go. That way you do not contact the the pupil margin. In case you can't do that and you do have the trailing haptic left over, what you could do is push the haptic in a trailing haptic in a manner that you're actually compressing the leading haptic optic junction, and so that the trailing haptic clears the pupil margin ring complex. And you do not really push that ring complex, because otherwise the ring complex would go into the bag. If you have a situation like that, you can cut that ring and take it out, but it does get a little messy. So you don't want to push the ring into the bag. Now, how do you remove the B-HEX? The easiest is to remove it through the main incision. Just grasp that flange which is anterior to the iris, advance it centrally, untuck those two flanges on either side, and just draw the device out. You do not need to untuck the other flanges. They just untuck spontaneously. It works so easily. And this is, of course, the biggest blessing of B-HEX. You can remove it through a 1 millimeter incision. Works very well in IFIS and shallow anterior chamber. No other device in the history of ophthalmology can do that, apart from iris hooks. No ring can do that. So these are our publications. A couple of publications from, there's a publication by Dr. Ryan Monto, Dr. Devdulal, and Dr. Arup on VR surgery also, and then JCRS and IJO. If you would like to read more about the B-HEX tips and tricks, you are welcome to download this document. It's a PDF document with video links available at our website. The page is B-HEX Pupil Expander and subpage Ophthalmic Surgeon. And it's got lovely videos which are timed to the scene. So you can just click on the link and you reach that scene. If you want to read a little more on small pupil tips in phacoemulsification, please visit, I'd encourage you to visit eophtha.com and take a look at this article. Thank you very much for your attention.